Okay, hopefully you guys can all hear us now. So welcome to Fertility Factor Fiction, one of the best shows on the web where we present live data every week, review either an existing or upcoming article, and then go on to take your questions live and try and help you all through your fertility journeys. So we've got a great topic tonight, an upcoming paper from Fertility or Sterility talking about what elements of intrauterine insemination are actually predictive of your outcome and whether or not you can predict outcomes. And I think this is a really eye-opening article for a lot of people because it's got several points that are really critical. And we end up focusing a lot on IVF in the infertility world, but IUI is actually far more common than IVF. And so it makes a lot of sense to spend a good deal of time dealing with that. So we want to make sure that we are covering those bases because many of you are exploring that potential avenue of therapy, and we want to make sure that we're addressing that for you. So hopefully you've all had a good week. We always give everyone a minute or two to jump on board, so we chit-chat at the beginning. For those of you that have been vaccinated, my understanding is that that is very protective, and I've now finished mine. As you can see, I did not grow a second head or any extra appendages, so nothing terrible happened to me. In fact, despite all the rumors, with my second dose, I had absolutely nothing other than a sore shoulder on the left side where I had my shot, and I had it in the same place the first time. You actually don't even feel them giving you the needle, so that's really the impressive thing. And then afterwards, it was just sore for a couple of days. No fever, no chills, no weakness, no fatigue, nothing. I felt great actually, so it was pretty easy to deal with. If you haven't been vaccinated, hopefully you will be soon. Nevertheless, the rates of infectivity have plummeted across the world. It's down 70% in Canada. It's down 76% in the US, which is really helping to drive down the rates of complications from this virus. So hopefully we are nearing the end. I certainly don't think we're there yet, but I think we're getting there. And so hopefully you're all staying safe in the meantime. Okay, so hopefully you guys have all had a chance to jump on board. You got your tea or your coffee or something good to eat. And as always, grab some chocolate, dark in particular, it's good for you. So this study is called Clarifying the Relationship Between Total Motile Sperm Counts and IUI Pregnancy Rates. So what this group did, it's an American group. They took a very large data set from one center and compiled a huge analysis of what was predictive in terms of IUI success. And the numbers are really quite staggering here. So this study involved 92,471 insemination cycles. So this is a very large data set. And what they most wanted to know was whether or not your total motile sperm count, TMSC, was predictive of your outcome. So in other words, if you do this quick calculation, and I'll explain that in a minute, does it help predict what your outcome is going to be? So the total motile sperm count is the volume of sperm of ejaculate times the number of sperm times the percent that are motile. And that gives you a number. It does not account for the number that are abnormal, which is important because the ones that are abnormal traditionally are believed not to work. But currently, if you use what's called the strict criteria, you actually only need 4% normal to be normal. So, you know, that's probably playing less of a role. And so you have this total motile sperm count. And the question was, is there a threshold, a certain number above or below which is not worth doing IUI, or you get a huge increase or a huge decrease? And so they basically took this massive pool. They analyzed that number, and then they did something extra where they controlled for the confounding variables like age and body mass index and so on to see if they could get a slightly more robust answer. So we'll go through the positives and we'll go through the negatives and we'll talk about it. So first thing is just the numbers, right? So as I mentioned, 92,471 insemination cycles. So a huge number. They did lose a lot of them when they went to do the sub-analysis to estimate what the impact of the confounding variables were. So almost 30,000. They were down to 62,758 cycles, but still a huge, huge number. And so they go through this and they analyze all of the different variables to see what the impacts were. So they used anybody that took Clomid or took letrozole or did FSH, which are the injectables. They did not do natural cycles. Everybody had some type of medication, so it was not natural. They did also include the patients that had clomiphene and FSH injections together. And that's important as well because that can often help people keep their drug costs lower, but end up helping them with the extra little boost that you get from doing the injectables. The protocol was basically a standard protocol, and they used one of two types of sperm preparation protocols, one which is the centrifugation gradient, and that's quite common. And then they used another one where they had more of a swim up method. So all of that was pretty standardized. Okay, the total number of patients, 37,553. So again, a huge, massive number of patients. And so what they did with all of this was they said, let's have a look first, and we're going to turn to table 1. And we're going to go over that. They said, let's have a look and see, let's just break apart the numbers and see if there's a threshold above or below which there is either no difference or a significant difference in terms of outcome. So we got table 1 up there. Fantastic. So if you're looking at table 1, you can see that the very first row, less than 0.25. So this would be considered an extremely low total motile sperm count, right? So you've got less than 250,000 sperm per milliliter, total of less than 250,000 sperm that are in this total motile count. So that accounted for a small number of their cycles. Obviously, most patients with such a low number would go towards IVF. There were only 263 patients, but almost 2% of them actually got pregnant. And these are clinical pregnancies, so they actually could see a heartbeat. Now, granted, not all of those are going to go on to have live births, but that's pretty robust data, and most of those patients will go on to have a live birth. So even if you have a terribly low sperm count, this is showing you that you still have a 4.2% chance of success, which is fantastic because lots of people come in and they're told, oh, nothing but IVF is going to work. And the truth is, that's never true. And I tell all our patients, look, it's going to be difficult. It may be very tough. You may have to try numerous times. And in the case of 4%, you're talking potentially, 25 tries before you're getting to a successful outcome. And it doesn't even actually work that way. It'd be more than that. But nevertheless, there is a chance. So if someone ever tells you your sperm count's too low, you can't do insemination, that actually is not true. You can do insemination. You just have to be prepared for a low percentage chance of success. If you go down a few rows, you can see once you're over 1, you're getting about a 7.45% success rate. So even a really low count still with that total motile sperm count, you're still getting a decent chance of success. The real threshold number they reached was when you get over 9. Once you're over 9 for your total sperm motile count, motile sperm count, you actually have a 16.7% rate, and above that, it actually made no difference. Whether you went even higher or you stayed at that 9 level, there was no increase in success. So there's two really important factors here to remember. Number one is that threshold of 9 is easily calculable by any patient on their own. You just need to know your ejaculate volume, you need to know how many are in each milliliter, and you need to know how many of them move. So you can figure out from this table where you're going to land and where your numbers are, your percentages. The other thing that's really critical to remember here is 16.7% were getting pregnant. So people always come in after they've done an IUI and say, why didn't it work? Well, keep in mind, even under the best of circumstances based on their calculation, you're getting a 16.7% overall rate. So this is including the clomids, the letrozoles, and the people doing the FSH. So at the end of the day, you've got to be very realistic about your expectations for IUI, because while it does work, you're getting that 16% chance. It's not going to be 100%. It's not ever going to be even close to 100%. And we do have other studies which we've reviewed previously on the show, which show that for younger women, once you get up to 6 tries, it doesn't work beyond that. And for older women, once you get over 3 tries, it really doesn't have a benefit either. So this 16.7% is per cycle, but keep in mind that you can't keep doing it in perpetuity. You will eventually tap out your success rate. All the numbers that were below 9 progressively went lower. So 14.3, 13.9, 12.87, 11.6. So as you can see, there's a decrease in your success as your TMSC goes down. So the next thing they wanted to do, and we're going to go to figure 1 here, the bar graph, is they broke it down into different categories of confounding variables. So what's the impact of age? What's the impact of BMI? What about the stimulation protocol? And what about the cycle number if it was your first or your second or your third cycle? So these are all really important things to look at as well. So when you look at the impact of age, age has a very significant impact, right? If you're less than 35, that success rate was actually 18.5%. 35 to 37, it's 15%. 38 to 40, it's 13.4%. And over 40, it's 11.9%. So that is a statistically significant decrease in success with each incremental increase in age. And we all know that that's true, but these numbers are really important because they're big, they're robust numbers, right? So I can tell my less than 35-year-old that overall you have about an 18.5% chance. I can tell my over 40-year-old you have roughly about an 11% chance or 12% chance. And that's really important to factor in. Interestingly, when they looked at BMI, they actually saw no difference across the different bands. Now, they haven't factored in other things here, including diabetes or whether or not your diagnosis was PCOS or whether you're a smoker or a drinker or a marijuana user. I mean, there's lots of factors that go into this. This is just purely based on the BMI of the woman. And with that, they're demonstrating that there is no statistically significant impact of BMI. Interesting, because we just presented last week or 2 weeks ago that BMI actually does play a role. So this is the wild world of infertility. One study will show one thing and another will show another. But the study we reviewed pertained to IVF, where we know for sure that BMI has an impact. This is insemination, where it looks like it does not have as much of an impact, if any. When they looked at stimulation protocol, you can see that when you took injectables only, it was a 19% success, so that's quite good. And then when you took clomiphene and FSH, you had a 15.2%, and clomiphene alone was 16%. So interestingly, no difference between the Clomid FSH or Clomid alone, so obviously no need to add in the FSH there, but the FSH alone has a higher success rate than using FSH with Clomid or Clomid alone. So big difference there. Unfortunately, the shots are expensive, and that's often the barrier for us. Or if you're a PCO, you got to be really careful because we can easily turn you into Octomom. And then we're all on a TV show together, which we definitely want to avoid. When they looked at cycle number, they showed no statistically significant difference. So it didn't matter if you were in your first, your second, or your third cycle, they had the same numbers there. So if you flip to table 3, they actually show what the final outcome of all of this is. And they say your cycle outcome has a 2% difference. So they did find a bit of a difference there, but it's really, really minimal. Overall, cumulatively, they're saying up to 3 cycles, you get a smidgen of an increase, and that's a 2% increase, which is clinically kind of meaningless, to be honest with you. Age had a significant increase. So for every change in year, you're getting a 5% decrease overall in success. Body mass index, they said, had no impact, and the Clomid only had no impact. But when you jumped into the follicle stimulating hormone, the shots, you had a 27% increase in success rates for clinical pregnancy. So why is this important? Well, there are 2 critical elements to take, or critical messages to take from this study. Number 1, these guys obviously have a huge database, and from that, they've been able to tell us that if you calculate the total motile sperm count, and get that number right down to a precise number, you can tell roughly what your threshold of success is going to be just based on one simple calculation. So can you predict? You actually can. According to this, that number alone is sufficient to give you a very reasonable breakdown of where your chances are going to fall. The other thing that's really important from this is to understand that the numbers are very modest. So even in the best case scenario, the highest percentage they have here is looking at that shots only group where they got an overall maximum percentage of 19%. So the success rates with IUI are always going to be modest. So when you're going down the IUI route, it's really critical from an emotional standpoint, from a financial standpoint, from a stress standpoint, even your relationship, all of those things. You need to go into it prepared for the fact that you may actually need to try multiple times, and even after trying multiple times, it may not work. You may still need to go to IVF because once you hit that limit of 6, depending on age, or 3 if you're older, it's not going to work beyond that, and you're probably throwing money, valuable money away. And in particular, if you're in the US where the IUI itself is insanely expensive, that's not going to be worth it for you. You're probably better off saving up your money, going to a lower cost IVF center and doing your IVF there, because your chances are going to be so much further ahead. So you got to be realistic about the expectations from an IUI cycle. It is not going to give you an 80% or a 90% or a 60%. So when you don't succeed, the answer to why it didn't work is often that's just the biology of what's happening. There is no way to improve it. So is it a factor of fiction that you can use your total motile sperm count to predict your IUI success? It's actually a fact. And there are several other factors you can use which are important, including your stimulation protocol and your age and the number of cycles that you've done, all of which can contribute to an improved success rate. And knowing what you are getting going into the cycle should really help guide your decision-making process. So I hope you found that useful. Make sure you like, comment, and share. We'd love for you guys to share the findings with your friends and other people you know of that are struggling through their own infertility journeys. And make sure that you let us know if you have any questions or concern. We are always happy to answer them. And I've been jumping onto YouTube more lately to try and answer your questions directly as well. So we're going to go on to the live portion of the show. If you want to ask us any questions, you certainly can there. And we have a number of people that posted questions earlier on already for our Instagram. Do you need my phone? All right. Here is my phone.
So I'll give you one from YouTube in the time being.
Yep.
I read that there is no further added benefit when there is the sperm count is above 10 million for IUIs. Is that true?
Well, based on this data, yeah. Now, not the sperm count, but the total motile sperm count. They're saying that 9 is the threshold for success. So if the sperm count is above 10 million in the final sample, then yeah, there's probably no benefit going above that. We have reviewed a previous study on the show which said actually their cutoff was 14 million, and that was also a really large database. So it's probably in those, 9 to 15 or 9 to 20 million. That's probably the sweet spot for IUI. Above that, you're probably not going to get much of an added benefit to doing it. And below that, there is probably some degree of decrease in success.
Hello, Dr. Victory. I have 2 questions for you. What is the optimal iron levels for pregnancy? I used to be anemic, but my last lab probably over a year ago, I believe was 45. How much ubiquinol can be absorbed at once? I read that your body can only absorb 100 milligrams at a time, therefore need to be taken several times a day.
So ubiquinol doesn't need to be taken several times a day because of how much your body can absorb. The problem is it's absorbed very poorly. So you have to take a lot in order to get any kind of absorption of the ubiquinol. Ferritin levels that we look for in pregnancy, it has to be over 15. To have a normal ferritin level while you're trying, it's much higher than that. So 45 is actually low for a normal ferritin level. In a pre-pregnancy state, during pregnancy, our cutoff is 15. So ubiquinol, just to quickly go back to that, We used to import a product from the US. I forget what it was called, Neo Q10. And it was from a company called Theralogic. So great product, like amazing absorption of their coenzyme Q10. They had this patented technology, and they had this great little display where they would put it in water and you'd watch it fizzing away. And the one from Kirkland looked like it turned into chewing gum, and the one from these guys completely dissolved so you could absorb it. About 20% of our patients developed a rash from taking it, so we had to stop using it because it was like just making them have these terrible reactions. So it's hard to absorb CoQ10, and when they make it so you can absorb it, I think it can be a little bit of overkill. So you have to be cautious, but there's not a problem so much with the absorption of it. It's more of a problem with, or the amount that you're absorbing. It's more of a problem with the fact that your body doesn't absorb it very well. So most of the time you have to take about 600 milligrams just to get a sufficient amount into your system. Yeah, great question.
What to expect during the first consultation appointment?
So we have a YouTube short on that. It's part of our Fertility Basics series, so you can look it up there. But it's pretty easy. We do a full detailed history. We go over everything about you guys, so it's very detailed. I want to know how long you've been trying for. What are your periods like? How many times a week are you having sex? We want to know about your previous medical history, your previous obstetrical history, your gynecologic history. Were there any sexually transmitted infections? We want to know how heavy your periods are. Do you spot? Do you have long periods, short periods? Are they painful? Is sex painful? We want to know about your surgical history, your anesthetic history. We want to know about your psychosocial history. Do you smoke? Do you drink? Are you a drug user? And that goes for the male and the female. And then we want to know about allergies. We need to know about your height, your weight. And then once we've done all of that, we have a long discussion about what is involved with infertility. And then we talk about what testing we need to do. And then we organize your tests. If you have recurrent pregnancy loss, we also delve into the whole history of your previous pregnancies. What were they like? How far did you make it? What testing have they done for you? What treatments have you tried? Same thing with fertility. If you've done fertility treatment, I want to go through it line by line. So I spent about an hour last weekend with a couple who had done multiple cycles of IVF without success at another center. And then I spent another hour with them yesterday going over all the details because they sent me a digital file yay big and I had to go through it line by line. And looking through that, I can always detect things that I think we should do that maybe have not yet been done. And so I spend some time doing that for the patients to figure out what's going on. So I did do that in their case as well. And we found some stuff that might be useful for them that can help with the procedure. And so I think that kind of detailed look at things really makes a huge difference because there are people that just don't get the right treatment. And when they don't get the right treatment, you need to do what's necessary to correct it.
Thoughts on different blastocyst cultures, namely embryogen / blastogen, which is GM-CSF.
So there are good studies on that, and using GM-CSF in your blastocyst culture can actually improve things. They've got a couple of randomized controlled trials. It's still a little bit up in the air as to how much of an impact that has. There's also some concerns that have been expressed that it might be messing with the quality of the embryos. So keep in mind that even though it looks like it's beneficial, it may actually end up having some side effects that we don't know about yet. So end of the day, we do use it from time to time, but it's not like a mass thing where we use it for everybody, and it is very pricey to get those medias with the GM-CSF in it.
Can you explain the prenatal screening testing and why you may get a positive result?
So if you're talking about early first trimester screening, it looks for anywhere from 3 to 5 proteins or hormones. And then it looks for the nuchal translucency, which is the thickness of the back of the baby's neck. It's usually done between 11 to 14 weeks. And some places do it in 2 stages. There's an earlier one and then a later one. Some places do it all at once. In Ontario, we do it all at once. So the test is not a diagnostic test. It does not tell you yes or no. It only tells you what your chance of the baby having Down syndrome is. So it's not going to say your baby's positive or your baby's negative. It says you as an individual with the numbers you have and all the calculations that they do, have a 1 in 5,000 chance, or a 1 in 2,500 chance, or God forbid, a 1 in 3 chance. So the higher the chance, obviously, the higher the risk that your baby has Down syndrome. And we don't really get nervous until it's really quite high, because just doing the percentages, the cutoff is usually somewhere around 1 in 350. And so at that level, you have a 0.3% chance that the baby has a problem. So you've got a 99.7% chance that the baby's fine. But because it's higher than they arbitrarily want it to be, at that level, they then trigger the next test, which is NIPT, a non-invasive prenatal test, where they can actually pull the baby's DNA out of your blood. And when they do that, they can analyze that DNA, and that has a 1 in 10,000 error rate. So technically speaking, it's still a screening test. It's not a yes/no, but it's pretty much a yes/no. They do recommend you have confirmation with an amniocentesis, but the reality is if you have a positive on your NIPT, you have a very high likelihood that your amnio will come back positive as well. So that's what first trimester screening is. And the reason you're getting what you think is a false positive, it's not a false positive. If your chance is 1 in 200, you've passed the 1 in 350 threshold, they're telling you you've screened positive. It still means your baby has a 0.5% chance of having Downs. So you don't have a positive test for Down syndrome, you have a positive screening test, which just means your threshold was above what they're comfortable with. They want to do the extra test to make sure you're safe.
A lot of questions today, just so you know. So prepare yourself.
Okay, fire at will.
Do you recommend being vaccinated during fertility treatments?
Yes, so don't do it during fertility treatments. Do your vaccination, wait 2 months, and then go ahead. We know that the viral buildup, the antiviral buildup takes about 2 months to peak, and then it remains stable after that for many months forward. So during that buildup time, you probably don't want to do anything because your immune system's like in go-go mode. But after that, it's stabilized, and the overactivity of your immune system should be settling. In fact, technically that's at about 6 weeks. So if you start at 2 months after your first shot, you should be perfectly fine to go ahead and get pregnant. But don't get pregnant, and no one is recommending that you get pregnant within the first 2 months after your vaccination.
You ready for a new question?
I'm always ready.
Never in my life have I read it.
Okay.
Is bisexuality quite common among men and women whose mothers received additional dose of the sex hormone progesterone while pregnant?
Wow. No idea. Never seen that before. Never heard that before. And it would be super hard to study. Having said that, most patients doing IVF have had progesterone exposure while pregnant, mostly in the early trimester, and therefore that could actually be studied, but I don't believe it ever has been demonstrated, although I don't know that anyone's ever looked at that. So phenomenal question, no idea. And I don't think anyone knows. I'll look it up though.
That's a good question.
That's a great question. Yeah, that is a really good question. Yeah, no idea.
Is it normal for a normally regular cycle to be impacted following doing a luteal stim phase? Have done 9 back-to-back IVF cycles in 12 months, and the last cycle was a luteal phase stim. And now my normally regular cycle is quite late and BFN.
Big fat negative. Yeah, so yes, a luteal phase stim will totally mess up your normal cycle completely. So that'll alter everything. And if you've done 9 IVF cycles back to back, you need to be seeing somebody that's going to figure out why you're doing 9 IVF cycles, because there's absolutely no reason why you should be doing 9 cycles. So I'm sorry that you're going through that, but there's got to be an answer rather than just try again. So maybe reach out and I'd be happy to help you out. We got to figure out why it is that you're having to try so many times without success. I've never in my life done 9 IVF cycles. And in fact, I would probably refuse to do that because it doesn't actually make any sense. Something has got to give if you're trying 9 IVF cycles. I got dust flying around here. Okay. By the way, we should give that other person some kind of prize. I don't get stumped very often, so we got to give a stumped victory prize. All right, go ahead.
Stump victory prize. I like that.
We should do that.
Stump Dr. Victory.
Try and stump Dr. Victory, yeah.
Okay, my WBC white blood cells, I'm assuming, is a little high of 10.3. And my neutrophil is also high of 7.5.
Okay.
Does this have any issues with the transfer?
So only if you have some sort of immune problem. Otherwise, no. I mean, we don't ever look at your white blood cell count or neutrophil count before we do a transfer, unless you have a known immune-mediated infertility or recurrent pregnancy loss problem.
Instagram now. Giving a little for the gram.
IG.
Yeah. Does the HCG wash you use during transfer show on a pregnancy test like a trigger shot does?
Yeah, so interestingly, it can if you do it too early, but HCG, no matter where you put it, washes out of your system 5 days. And with the very small amount that we're putting in your uterus, it definitely washes out. So if you've got a positive preg test within, like, say, 8 or 9 days after transfer, which is early and you shouldn't be cheating and doing that, then you are probably pregnant. It's not from the HCG wash.
Another HCG question.
Okay.
My doctor will not do an HCG wash before the transfer. I'll ask him if he can prescribe a Gonafil 0.1 injection subcutaneous which day after transfer. Should I inject this? Thank you.
A Gonafil or a Gonal-F? Oh, Gonapeptyl.
Gonapeptyl. Another stuff.
No. So I'm not familiar with Gonapeptyl, but that's probably a version of Lupron. I'm assuming, like a GnRH agonist. So you definitely don't want that after transfer. That actually makes no sense. If you're thinking of an HCG, if Gonapeptyl is HCG, why won't your doctor do an HCG wash? Just show them the evidence. Show them our video. We reviewed a paper. There's a meta-analysis that shows that it improves the success rate. So it's kind of silly for them to say no. And remember, you are in charge of your journey. No one can tell you, what they will or will not do. And if they're saying no, then take your embryos elsewhere and get someone that will do it. Like, to refuse someone something so basic, which is proven to be beneficial, actually makes no sense whatsoever. Like zero. That makes no sense at all. So yeah, don't do that with that person. Find a better doctor that's willing to work with you. I mean, I hate the fact that you guys need to advocate for yourselves, but unfortunately, all too often in infertility, you need to advocate for yourself. So if you want something and your doctor's not doing it, then go somewhere else. I mean, those doctors need to learn that there are consequences for not doing what their patients want. I work with my patients. We talk to them. Sometimes my patients have ideas I don't agree with, but if that's what they want, then that's what we're going to do. I mean, barring something that's clearly going to damage your embryo or your chances, there's no reason not to try things in most cases.
When first starting with a clinic, how long does all the initial testing take before starting treatments?
On average, about 4 to 6 weeks, depends on where your cycle falls, but 4 to 6 weeks usually.
Is there value in prescribing letrozole for men?
If your guy is really heavy and he's producing a lot of estrogen, yes. So if he's kind of fatter or has more adipose tissue, then letrozole can be helpful. That's the main time where we use that.
Thoughts on men getting the COVID vaccine during fertility treatments when they are needing to provide semen sample? I've heard other women say their husbands' counts went down significantly between samples because they got a fever after getting the vaccine. My husband is a paramedic and scheduled to get the vaccine this week, and we have our retrieval mid-March. Thank you.
Okay, so by mid-March, you won't have a fever. And keep in mind that the sperm that we as men ejaculate today, we produced 3 months ago. So if you're getting your vaccine next week and you're doing something in mid-March, there shouldn't be really any significant impact from the vaccine. Having said that, fever or any heat to the testicles can negatively impact the quality of the sperm. And so that can occur even to sperm that's stored. So keep the testicles cool. So if he gets a fever, I hate to do this to you, buddy, but sit on frozen peas even while you're shivering from your fever, because keeping the testicles cool will protect them from the effects of the fever.
Fact or fiction? This is the question. Does using soft cups help with keeping sperm up at cervix?
Soft cups? I'm not familiar with soft cups, but I'm assuming you mean like a Diva cup, inserting it in after the sperm has gone in. Yeah, I mean, in theory, keeping more ejaculate there gives it a better chance. No one, keep in mind, knows exactly how this works, but the belief is that the reason men ejaculate with force is to actually shoot the sperm partially through the cervix as much as possible. It doesn't make a ton of sense because Lord knows it's not like we're aiming. But this is getting really graphic on this show. We got to flash one of those like not rated PG or something things here, right? Yeah, rated R. So the reality is that we don't know if that would help or not. I'm not aware of any data in that regard. It does make theoretical sense. At the same time, keep in mind that if you trap stuff up there, you're also trapping bacteria, which is the last thing you want getting in there with the sperm. So it may be advantageous, it may not be. The less foreign body in your vagina, the better off you are in general. So if you're going to do it, I wouldn't do it for more than 15, 20 minutes, an hour, that kind of thing.
If you have
Great question.
If you have a unicornate uterus, how does ovulation work? Do you ovulate 1 month yes, 1 month no?
No, your uterus is totally separate from your ovaries. So a one-sided unicornuate uterus will still have the ovary ovulate from either side. Interestingly, one tube, if you only have one tube, can pick up the egg from the other side. We don't know how, but it does sometimes. But you ovulate usually alternating between one side and the other, but your ovarian function has nothing whatsoever to do with the uterus.
Is it okay to take daily antihistamines when going through fertility treatments?
Yeah, for sure. That's being looked at. In fact, some people use it as part of their therapy, so there's no harm to that.
Top of the evening, Dr. Victory.
Top of the evening.
First question. Do you have an office here in Chicago? Second question.
Oh.
Taking hydrochloroquine for arthritis,
Yeah.
can it affect you with your IVF treatment?
Yeah.
Can it hurt the egg count?
Okay, so I do not have an office in Chicago. However, if you live in Chicago area, the person that you want to see is Eve Feinberg. Eve is at Northwestern University. She is one of the smartest people I've ever met in my life. She's brilliant beyond compare. She's an absolute sweetheart. She has spectacularly high success rates. And she is the one I send all of my US patients to when I can't get them to get over to Canada so that we can help them. So if I ever had to start a fertility center in the Illinois area, it would be with Eve without a moment's hesitation. But I myself do not have an office in Chicago, nor are there any plans for it, although it is probably one of my favorite cities in the world. I love it there. So that's the Chicago answer. The hydroxychloroquine is likely beneficial. So there are multiple studies looking at the use of Plaquenil for fertility, and most of them suggest a benefit. There's certainly not going to be any harm.
What if someone has high morphology, motility, and sperm count, but your sperm volume is low, between 0.9 milliliters? Does that have a huge negative impact on getting pregnant?
Naturally it would, because remember, you got to get the ejaculate up there, and then it's got to kind of either get into the cervix or swim around there for a bit. So the lower the volume, the harder it will be. But again, it's the total motile count. So if you've got 0.9, but you've got 100 million, you've got 90 million sperm there. Some of them are going to get in. But if you've got 0.9 and you've only got 10 million per milliliter, you've actually only got 9 million. So if not all of them are motile, you're falling in that lower range as far as the total motile sperm count. So it depends on a number of different factors, but you want at least a reasonable volume. So I would recommend ejaculating every other day, take lots of fluids, keep your testicles cool, avoid smoking, drinking, drug use, all of those.
How long is the wait time if we wanted to become your patient?
Mara's going to kill me if I actually answer this. So Mara, if you're watching, I'm sorry. Usually about like a couple of months right now. We're getting busier all the time. And it depends on the urgency. So they triage the patients. If you're 40 and your ovaries are failing, obviously we'll see you sooner. If you're 22 and you have PCOS, you've got time. So understand that we respect your need to get pregnant, but we also respect the urgency of the 40-year-old whose ovaries are failing. So usually we can see you fairly quickly, and I pretty much work 24/7 now. So I'm working through the weekends. We're doing consults every weekend. I'm here often in the evenings. And so we work pretty hard to get to all our patients. And very soon, one of my colleagues will be joining me who will be taking over some of the more basic stuff. So she'll be doing a lot of the intake, and she's amazing and has been training with me for months. So you're basically getting substitute me, and she's every bit as good as I am.
Does using HCG as a man hide some risk like birth defects or problems with the child later when trying to conceive?
No. One word answer. Yeah, no, there's no negative impact of that. In fact, if anything, if your sperm count and performance improves, you're reducing your risks. So it's beneficial, not detrimental.
What's the reasoning for no increased benefit of IUIs when motile sperm is over 9 mil? Is this threshold the same for timed intercourse without IUI? This goes against the logic that more sperm, the better.
Well, keep in mind, there's probably a threshold of how much sperm can actually get through a tunnel. So your cervix is a tunnel, and there's only a certain concentration of sperm that's going to fit in the tunnel. And then it's got to get through the mucus, and then it's got to get through your immune system, and then it's got to get into the tube, all of which have stages. So think of it as like a crowd trying to enter a stadium, right? If your hallway getting into the seated area is this big, it doesn't matter if I put 2 million people behind me, I can only get this many people through the hallway at a time. So it's the same thing with sperm. The first guys are the ones that are going to get there, basically. So even if I piled 100 million more behind me, if there's a narrowing or a hurdle to get over, so to speak, then it's going to take time for everything to happen, and the rest of those guys might die or sit around forever waiting or whatever. So there is a threshold there for a reason. I don't specifically know why 9 million was the threshold in this study. That's just what their numbers showed. But the reality is that data is showing it's 9 million. Now, is it true for natural intercourse? We don't know, because they don't have a study like this, and we never will, because we don't get 90,000 people or 90,000 cycles of people showing up saying, test my sperm right before I ejaculate. We couldn't even do it. It doesn't make sense. So there's no way to know for a natural approach to things. Great question, though.
I'm 37. 4 PGS normals from only 4 tested, and all 4 from same cycle, but was my 4th retrieval. 3
Wow.
previous failed transfers of untested embryos.
Okay.
I only get pregnant on 10 mg prednisone.
Yeah.
What testing should I have before I transfer a PGS normal?
Lots. So the basics, so your hormones, your thyroid, your vitamin levels, vitamin D and iron in particular, all of those are necessary. Make sure your thyroid antibodies are low. Make sure your TSH is less than 2.5. You should probably get fertility testing if you've previously failed transfers. So www.fertilylys.com. You're looking for the hidden C, plus minus the immune testing if you think that's going on as well. Make sure your partner's sperm DNA fragmentation assay is being done because that predicts miscarriage risks and possibly failures as well, we think. Stay away from everything bad. That's pretty much the mainstays of the things that we do to check you out. We do recommend you take melatonin. We use letrozole. All the stuff that we've explored on the show that has shown a benefit, we use to help our patients get the incredibly high success rates that we are currently enjoying. So those are the things we do, and it's been working very, very, very well. Make sure your uterus is being explored too, so a saline infusion sonohystogram.
Hi, Dr. V. Is mild cramping during the 2-week wait after an IUI normal, or should I be concerned?
Mild is probably okay. If it's more so, we always worry about infection. It also depends on how many eggs you released. If you released 10 different eggs, then that's a concern because then we're worried that you're having pain from all the egg release. But if you release 10 eggs, you shouldn't be getting an IUI. So that's really critical.
I got your favorite question.
My favorite question. Drum roll.
Hi, Dr. V.
Hello?
Do you think of doing ERAS? What do you think?
What do I think of doing ERA test?
Yeah.
Oh, watch the show. Was it last week or the week before?
I think it's every week.
ERA test sucks. So the ERA test is useless. We just reviewed it. I think that was last week.
Yeah,
I'm losing track because we've been doing this for so long. Yeah, it's epically useless. It is completely useless. There is no value to doing the ERA test. Multiple trials have shown that it is of absolutely no value. I was actually chatting on the weekend with a very prominent social media fertility specialist who was talking about the ERA test. And I said to this individual that they should not be promoting it because it really doesn't work. And the response was, well, someone down the street does it from their clinic and therefore they couldn't tell people not to. But the truth is you can't tell people not to, and you should be telling people not to because it doesn't work. It's an enormous waste of money for nothing. And one of the studies we reviewed actually said it was detrimental, which I'm starting to believe too. So there are studies we've reviewed on the show that show that a day 5 embryo can be transferred on day 5 of progesterone or day 6 of progesterone with 0 difference in success. So it makes absolutely no difference. So that automatically negates the value of doing an ERA test. On top of that, there's an upcoming study coming out again looking at the relationship between the timing of progesterone with no ERA test and how people did with their embryo transfers. And I think they looked at a low of about 112 hours all the way out to like 140 hours. And so that again is looking at like basically 4 days or close to 4 days of progesterone, 4.5 days of progesterone, all the way out to like 6 days of progesterone, right? And this upcoming study showed no difference in success. And their conclusion themselves was, therefore the ERA test is useless. The ERA test is useless. Do not do the ERA test. It's a total waste of money. The only time I recommend doing the ERA test is if the lining is super thin and you just can't tell if it's going to work at all. Okay, then at least you know if the receptive bits and pieces are there, but ignore the timing component of it. The timing component is absolutely meaningless. It does not work. I've tried it. I used it extensively. It made no difference. Their own randomized controlled trial showed no difference. So don't do the ERA test. You're right, that is my favorite question. I get really excited about that one.
Is there an age where you would not recommend IVF or would not recommend transfer of healthy embryos?
Okay, so I don't recommend IVF to anyone if their chances are so poor that I think it's not worth doing. What's my threshold for that? 10% is my threshold for that. And I'm really honest about this with patients and say, your chance is this, and I try and calculate it for them as best as I can. And if their chance is less than 10%, I will tell them, look, your chance is less than 10%. You need to consider alternative options. Not that you have to, but you need to consider them. So I'm not saying you have to use a donor or you have to choose something else. but that it's important to at least think about a donor or think about some other options. Having said that, in terms of the age of IVF, realistically, once you're over 43, the chances are very, very low, no matter where you go. And in terms of the age of the parent, okay, so I have like a uncommon approach to this, I'm gonna say, right? So my theory is this: most kids are gonna move out of the house permanently, hopefully, by the time they're 24 or 25. Our son's home with us, but he's in law school and business school, and we love him dearly, and he's a superstar. So Matt, you're welcome to stay home with us for as long as you like. But most kids will be out of the house by the time they're 24, 25 in the pre-pandemic days. And God bless him, he was in his own apartment prior to the pandemic. So with that in mind, you want to be around till at least your kid is out of the house, hopefully getting married and so on. So let's assume 25. The average lifespan is around 80, 81 for a mom. So for a woman, so subtract 25 from 80 and that leaves you with 55. So I think 55 should be the upper limit for where we should be considering getting patients pregnant. I'm not saying it's a hard and fast rule, but I think that's reasonably sensible. Beyond that, there's a reasonable chance that you're going to leave your child orphaned. And even if they're a young adult, that's pretty hard to take. So I think that that age makes a lot of sense, but that's my very, very individual argument. Throw up some likes if you think you agree. I would love to know what your opinion is. What are your opinions? Everybody tell us what you think. Like, I would love to see what ages you guys suggest. Just throw up numbers and Tarek will get a summary. Or maybe, you know what we should do is we should do one of those polls on Instagram, and we can say, what do you think should be the age cutoff for? But you guys tell us, let us know. And if you're watching this later on, comments. We want to know what age you think is the maximum age.
What are your thoughts about starting a frozen embryo cycle with a 2 residual cysts after the egg retrieval cycle? Should it affect the FET?
Not if they're inactive and they're just, leftover cysts. So as long as it's not producing estrogen, progesterone, or anything, you're fine.
What are the chances for conception, natural or IVF, of all parameters are good, but morphology is 1 to 2%?
With ICSI, still very good. So ICSI solves the morphology problem because your embryologist, if they're good at what they do, will pick the sperm that are really good. So our embryologist is amazing. In one of our recent cases, that is a patient of a physician working with us. She had a case with very poor quality sperm and the morphology was terrible. And she actually got not just 100% fertilization, but 100% blastulation. So all the embryos reached blast and she froze them all. So if you get a good embryologist, you're going to get good results. If you get a bad embryologist, you're going to get bad results.
40, AMH 3.35 picomoles per liter. Got pregnant last year on the 3rd try, but lost the baby due to chromosome abnormalities.
Sorry.
I've done 1 round of letrozole. Would you suggest IUI or go straight to IVF at my age?
So that's a great question. The problem with that is that with a AMH of 3, your chances are low either way. So you have to be realistic about what your expectations are. Going into IVF with an AMH of 3 picomoles per liter, your chances of success are probably quite low. You're most likely looking at somewhere around a 15-20% chance overall. So if you are comfortable with that, then go for it. If you are not comfortable with that, then obviously don't. And if you are thinking IUI, your IUI success rate at that age with that low an AMH is really low. So keep in mind the study we showed does not break it down by AMH and by your residual follicle count and things like that. So it's going to be a fairly low chance. It's probably somewhere on the order of about 5% or less. So you have to be comfortable with the numbers and the finances. So that's what you have to use in your calculation. I think it's worth it if you can afford it or you have insurance for it. If not, then obviously if you can't afford it, don't do it, because we don't want to add financial injury to the emotional injury of having difficulty with pregnancy.
Hi, Dr. Victory. Husband and I had a phone consultation back in May, and you were concerned about my weight, so I decided to work on my weight before pursuing any fertility testing or treatment.
Awesome.
I have a BMI of 51 currently. Would a loss of even 5 BMI be a huge benefit for trying to conceive, or would I need to have a much larger BMI decrease to see any changes? Thank you so much for answering my question.
So first of all, if you've been trying to lose weight, that's awesome. The BMI really needs to be under 40 for it to be safe. And so I applaud you for your effort, and we're certainly happy to encourage you in that vein, but you need to get your BMI down a lot. At 51, it would actually be dangerous to get you pregnant, and we just don't do that because of the safety risks it poses to you. Plus, the success rates are dramatically decreased and your miscarriage risks are dramatically increased. So it doesn't really make sense to try at that stage. You have to get the weight down. About a year and a bit ago, we did review a really interesting study which looked, and it was from China, which looked at the relationship between body mass index to age. And there was a cutoff, if I remember it correctly, around 38, where it no longer mattered what your BMI was because your chances of success based on age were going down so rapidly, it made sense to try. So there are some factors that are important here, but if you're younger and your BMI is that high, you really should be losing the weight first.
Just want to say I love these Monday nights information nights.
Me too.
Can't wait to have a consultation with you. Super duper smiley face.
Awesome. Super duper smiley face right back at you.
How often would you advise having sex around your fertile window with high sperm DNA fragmentation? Every day or every other day?
So high sperm DNA fragmentation, probably every day. And on the day when you're actually ovulating once, and then 3 hours later again. Because they've done a study that shows that if you do another sample 3 hours later, you actually have much less sperm DNA fragmentation. So for about 3 days around the ovulation, every day, and the day of the ovulation, twice in the one day. And your husband didn't pay me to say that.
In your opinion, if I have high prolactin, 52 ng, and I'm self-pay, should I try to make lifestyle changes and get retested in 3 months, or see an endo right away?
You don't need an endo, just go on Dostonex or bromocriptine. But you need a macroprolactin test first, because prolactin can be falsely elevated by this fake prolactin called macroprolactin. So just get a blood test called macroprolactin. And if your macroprolactin is low and it's your true prolactin, it's called monomeric prolactin, that's elevated, just tell your family doc to put you on Dostonex. You don't need to see an endocrinologist for that. That's easy, especially at 52. There's zero risk it's going to be a tumor. So you don't need to worry. You can just go on the treatment for it, and that's really easy to do. So you don't need to see an endocrinologist and spend hundreds or thousands of dollars just to do something really simple like that. Great question. You got another one? All right. I wish you could see Tarek's expressions, because he's just excited too. So, yeah.
Hi, Dr. V.
Hello.
Thank you for answering these questions. My REI suspects I have Asherman syndrome after an ectopic pregnancy in July. Lab work indicates ovulation. Do you recommend your patients to do an egg retrieval and then do a
hysterosalpingogram?
No.
Hysterosonogram?
Hysteroscopy.
Oh,
and then transfer once healed. Any suggestions or recommendations to talk to my REI about this new diagnosis?
Okay, so first of all, an ectopic pregnancy cannot cause Asherman syndrome. An ectopic pregnancy is a pregnancy in your fallopian tube or outside of the uterus, and Asherman syndrome is scarring inside the uterus. So if your REI told you that your ectopic caused your Ashermans, your REI doesn't have a clue what the hell they're doing. That makes absolutely no sense whatsoever at all. So that's kind of kooky. So should you do IVF and then do hysteroscopy? Of course not, because if you spend thousands of dollars on your IVF only to find out that your uterus is damaged and can't be corrected, which can be the case with bad Asherman syndrome, then you now need a surrogate. And if that's not affordable for you, you just wasted thousands of dollars on your IVF. So first you get your uterus functional and then you do the IVF, because otherwise it's backwards and you could end up spending a ton of money on the embryo creation and then have nowhere to put them. Now, if you can afford a surrogate and that's not an issue for you, or you have a backup like a sister or mom or best friend or cousin or whatever the situation is, yeah, go for it, because then you've got a backup plan. But if you don't or can't afford to do that, then yeah, don't do the IVF first. You got to get your uterus checked first. And ditch that REI if they told you your ectopic caused Asherman syndrome. That's actually completely nonsensical. It makes zero sense unless somebody did a D&C on you at the time of your ectopic because they couldn't tell if you had an ectopic or not, which quite frankly is like dinosaur medicine. We don't do that. We just laparoscope and see if it's there.
9:02.
Oh, wow. Tonight flew by.
Time flew by.
Are we going to answer more of the pre-questions?
Let's answer some of the pre.
Yeah, just because people pre-ask, so we got to answer those. Okay, the last 15 minutes, we're going to answer the Instagram questions that people pre-asked.
Missed cycle after IUI with BFN. Told to start Provera to start cycle and then begin IVF cycle. Is this okay?
Yeah, that's totally fine. Not a problem at all. And I'm sorry you had a BFN.
Will mental stress, other mental health conditions affect my chances of pregnancy?
Yeah, so stress can reduce your chances by, in some studies, up to 60%. So if you are stressed, you need help to get your stress reduction down. That's why we spend so much time with our patients promoting our mental health program, which has amazing people like Darcy and Brenda. We've got our online program, Organic Conceptions. We used our naturopath, Jennifer Strong. She's incredible at stress reduction through holistic means and naturopathic means, acupuncture. So there are great ways to do it, and we have a really strong program in that regard. So do whatever you can to reduce your stress for sure.
Just how terrible is it to sleep on my back at 5 months pregnant?
It'll cause a stillbirth. Terrible.
Oh.
Don't do it.
I know that.
You didn't know that? Oh, Tarek learned something new. Big round of applause for Tarek tonight.
I would have answered that completely differently.
Really? Yeah, no, do not sleep on your back. So your inferior vena cava, the main vein in your body that takes blood from everywhere back up to your heart, is compressible. So if you put something on it, it'll flatten out and get occluded. And a great big uterus can occlude it. So what can happen if you're flat is your uterus flops back onto your back, and it flops onto the vena cava once you're past 20 weeks, and it can occlude the vena cava. Now, there was a recent study that said that didn't happen, but I think that's not a well-done study, because they've actually got ultrasound images of women that are flat, and within 30 seconds, you are reducing blood flow back to the heart. So it is not safe to be flat on your back. Put a wedge underneath you and tilt. You can be just tilted or sideways completely, but you cannot be flat on your back.
Dr. Victor. Your thoughts on natural killer cells, immunity, and secondary infertility. What tests do you do?
So there are tests we can do. We use Fertilisys, and they have a whole bunch of testing. So you can do blood tests, you can do endometrial biopsies, and you want to look for natural killer cells. different staining, CD57, T helper cell ratios, all of that stuff. So there's like a whole panel of testing that we do, complement levels, and all of these different things that go into the immune screening. To be honest, I like getting the involvement of one of my good friends, Fred Zaneku or Chloe Remain. They're both reproductive immunology specialists in Toronto. They're my partners in some regards, and they're fantastic at that stuff. So we get them involved when I think that there is an immune-mediated problem. It is not an area I sub-specialized in. It's their area of expertise, and we've been doing some great work together where our patients are getting pregnant, but I definitely have them involved at that point. Three heads are better than one.
How does MFI impact IVF protocols at your clinics, if at all?
So we do different techniques to try and minimize the impact of male factor. First, we start with improving the male factor. So vitamins, elimination of bad habits, smoking, drinking, drug use, cooling the testes, all of the things we can do, frequent ejaculation, to try and make the sperm quality better, we try to do before we do your IVF. So that's step number one. Step number two, when we get to the sperm, there are different techniques we can use. So we can have you ejaculate 30 minutes later. We can use the Zymo device to try and eliminate the sperm with high DNA fragmentation. And in some cases, our embryologist will use a swim-up technique, which is safer than doing the centrifugation. So there are different techniques we can use to improve it. And then we use ICSI for almost everybody because her success rates are so good with the ICSI. And so that helps, of course, with male factor as well. The protocol doesn't change, but the specific steps within what we're doing once we're getting to the fertilization stage and leading up to that stage changed dramatically.
SMC using a sperm donor. Can I use one vial for multiple rounds of IVF?
You can probably get away with using one vial. The only problem is we don't love thawing and refreezing and rethawing and refreezing. So it's better if you get multiple because you're going to end up doing a lot of damage to the sperm by thawing, refreezing, thawing, refreezing. So I wouldn't do that if you're planning to do multiple rounds of IVF. I would get separate vials for each cycle.
Is test ordered for new client and done before consult? Referral sent January 4 waiting?
No, we do the testing after we meet you because I need to know what I need to test you for. In some cases, the testing you do before you come here is not of any use because they didn't do the right tests or they didn't do it at the right time. And in many cases, we have to repeat it. In some cases, you haven't done anything. In some cases, people get all these tests and I find out none of them were really helpful. So don't bother doing your testing before you get here. We only need a month to 6 weeks to get your testing done, and then we can roll you into treatment shortly after. So be patient for that month to 6 weeks. I know it's hard, and I apologize for the fact that it's hard, but that's really worth it.
Is the NIPT test accurate for twins?
Yes, but the NIPT test can't tell you which twin has what. So if one of them is affected, you'll pick it up, but you won't know from the test which twin it is because you're not testing the twins, you're testing what's in mom's blood. And it's a special NIPT that can actually distinguish for twins.
Hi, Dr. Victory. I spoke to you on the 17th. You told me you were going to call me back same day. Haven't heard from you yet.
Yeah. Write down the name. I don't know why that's the case. Don't broadcast it, but write it down.
So I don't lose it.
Yeah.
Okay, while I'm writing the name. What test should be done before IVF? HSG, SIS, semen analysis, blood work for hormones, anything else?
Blood work, saline infusion, sonohistogram, semen analysis. I'm thinking more and more sperm DNA fragmentation testing. Vitamin levels, vitamin D, probably your AMH, prolactin, thyroid and thyroid antibodies, ferritin levels. That's pretty much it. Sexually transmitted disease screens, obviously. That stuff's important too.
Low estradiol on CD3, what it means and its implications on an IUI cycle.
Low what?
Low estradiol?
Yeah.
on CD3,
cycle day 3.
what it means and its implications on an IUI cycle.
Not necessarily anything. So we don't really make a big deal out of estradiol levels unless they're high. Your estradiol levels can be low for a variety of different reasons, so don't pay much attention to those. We really don't track those very carefully.
Is Zfb test worth it?
You're such a... I'm going to kill you for that one. Okay, so I have no experience with the ZFB test. I actually had to look up what the ZFB test was. From what I can understand, it's another variation of one of these tests that tells you if your endometrium is receptive. All of those are useless, so don't bother.
Basal testing, fertility massage, acupressure,
I saw that.
CBD, allergy testing.
That's like a
What
hodgepodge
do you want?
question. Yeah.
What do you want?
Okay, so go through them one by one. What was the first one?
Basal testing.
If you mean basal body temperature testing, no, it's useless. Just use an ovulation predictor kit. Next.
Fertility massage.
Fertility massage, there's absolutely not a shred of evidence that it is useful. Next.
Acupressure. Maybe acupuncture.
Acupuncture has some benefits, although it's iffy with the fertility world, but yes, it does look like it can be beneficial if it helps you relax. Next.
CBD.
Avoid like the plague. Bad in every regard, no benefits, lots of detriment.
Allergy testing.
If you think you have an immune problem, sure, but we don't do allergy testing, we do immune function testing. So two separate things.
Top recommended brand for prenatal melatonin dose and men's vitamins.
Let's do that in a much easier way. So you've got to put up the
Okay.
the link.
That was coming.
Yeah.
Just
So
point
we
to it,
have
go
a
for it.
we have a video on that with Jennifer Strong, and we compared the vitamins. So look at that video. I think it has about 3,500 views now. So check out that video. It's got all the information you want. It compares all the vitamins. She likes the NFH product called Prenatal SAP. So that's a great product. Probably the next best we evaluated was Pregvite Folic 5. And then the next was Progesti, and then there's a bunch of other ones. So those are all good products. In terms of melatonin, 3 milligrams, and the last one was male vitamins. The two brands we use, and I don't get paid by anybody for any of this stuff, guys. I have no sponsorship or support or anything. We use Pro Fertile and we use Fertile Pro, two like terrible names because they're virtually the same, just backwards. So they're both great products. Fertile Pro, you need like 3 different vitamins for a male. Pro Fertile is just one. They're both good products. So use either one. Pro Fertile is a bit more expensive, but has very good scientific backing to support its use. Fertile Pro is cheaper, but doesn't have the scientific backing. It doesn't mean it doesn't work. They just didn't run the studies.
Happy Monday, Dr. V.
Happy Monday.
Just curious, the process after my husband and I have completed all of our tests and cycle monitoring. Should I call the office to follow up to discuss where we go from here?
Yeah, so if you look at the instruction sheet we gave you at the very bottom, it says, and we tell everybody to read that instruction sheet. So at the very bottom, it says, if you are done all your testing, call the office to book your follow-up appointment. So if you finished all your tests, call the office to book your follow-up appointment.
Is there... Oh, I think we read this. Oh, we could be done. Hold on. Yeah.
We're done those ones?
These guys are done.
Anything else?
They've been... Well, anything else is a big... That's up to you, man.
It's 9:15.
Yeah, I know. Up to you.
Pick one last good one.
Oh, I got the pressure.
Yeah. Those of you that don't get your question answered, by the way, it's all Tarek's fault because he didn't choose your question, so I'm innocent.
There you go. I'll go with a nice and easy one.
Okay.
Oh, somebody said I missed their question. Wow, there's pressure. Let's see, where's this guy's question? All right, I'll ask you this guy's question.
All right.
Give me a second to find it. You sure? Where is this question? You should just ask it again.
I don't think they can hear you, man.
Okay, here you go.
Okay.
How does BC priming work to line up all the eggs to grow together? Can it over suppress if I'm on BC more than a month?
So it works by just stopping your eggs from going through their developmental phases, so they all kind of line up so that hopefully more of them grow together. It's not that all of them grow together. Can you be oversuppressed? Yes. So in particular in women that are older, it's not beneficial. In women that are younger, it probably doesn't make a difference. But you can get oversuppressed to the point where you don't respond. And if your LH is very low at the start of the cycle, make sure that they don't give you a pure Lupron trigger, because it will not work. You have to give some HCG. Okay, we're done. I'm being instructed it's time to stop because my wife is going to kill me. So thank you all for joining us. As always, make sure you watch the videos, like, comment, and please, please, please share. So if you're on Instagram, our challenge to you is share with at least 2 people today so that we can help our community grow. And hopefully we'll have many more and many more questions. If you have questions that you did not get answered, feel free to message us. I will get back to you with answers. I almost always do. And we hope that you have a great week. Stay safe, wear your masks, sanitize, and we will see you again next week with another exciting episode of Fertility Factor Fiction. Have a good night, guys.